Hi, I'm Clyde Yancy, Chief of Cardiology at Northwestern University Feinberg School of Medicine and Associate Director of the Bloom Cardiovascular Institute, and I'm serving as Director of our Cardiovascular Update, the 8th time we're doing this, where we bring together really talented, thought-provoking speakers from across the country, blended with our faculty, to introduce to our audience, our virtual audience, what are the topical things that we think are germane in our treatment of patients today, and what do we need to know exactly about these topical issues? I'm really enthused to welcome Anne-Marie Navar, who is here visiting with us from Duke, and has really established herself very quickly, very young in her career, but very established as a thought leader, as an investigator, thinking very precisely about how do we prevent heart disease, and particularly how do we prevent heart disease when we target atherosclerosis. Dr. Navar, welcome. So delighted to have you here.
Thank you for having me. It's a pleasure.
Well, it's been a joy to have you here. You know, it's a great story to tell, because if you look at what's happened to heart disease and the risk of death over the last several decades, 50% reduction is legitimate. Half of it is from therapies that we've instituted, and half of it is from prevention. But there's this beautiful intersection where we have therapies that target prevention that seemingly have worked really well. And we started, if you will, in the old days with like nicotinic acid and niacin and things that made people almost revolt. But then we evolved to statins. And many people believe that statins didn't just change cardiovascular disease outcomes. Statins have changed society because people are living differently and are free from some of the burden of heart disease. I mean, give us your perspective. That's an incredible arc, an incredible story to tell.
You know, the story of statins is really exciting, because if you look at the series of studies, starting with the early days of the 4S study, basically every time we lower the bar for LDL thresholds to evaluate statins, the trials are successful. So every population that they're studied in, we continuously show not only can we prevent recurrent heart attacks and strokes in people who've already developed cardiovascular disease, we can actually prevent atherosclerosis. And the ability to identify people early on, get them on the right therapies, get them on the statin and lower their LDL, and actually prevent or push out the development of atherosclerosis far enough down the lifetime that they don't ever have to worry about it, it's really transformative.
I mean, think about what we just heard. You use the phrase, we can prevent atherosclerosis, we can push disease out into the distant part of the lifetime, and we can do that with therapies we have in hand. And think how infrequently in medicine we have proof of concept that is irrefutable, that something causes disease, and when we intervene, it relieves the burden of disease.
Not to mention that statins are generic. You can get just about any statin for under $10 a month, and they're probably one of the safest therapies across the armamentarium of medications that we use in primary or secondary prevention. So there's a massive public health benefit to the advances in statins, and it's really exciting to be part of that.
I want to get back to some very specific thoughts I know you have about some ongoing impediments to statin use, but that armamentarium word really captured my attention, because you are correct. It's no longer just statin therapy, and you've been really uniquely involved in thinking about and developing some treatment algorithms and concepts about a new class of drugs, PCSK9 inhibitors. These are drugs that when we as a cardiovascular community hear the data for the first time, standing ovation, like you immediately see the impact. So give us your perspective on that new class of drugs.
Yeah, so the field of lipid management and treating lipids to prevent heart disease has just exploded, and the last several years have been really exciting. The PCSK9 inhibitors, monoclonal antibodies, injected every 2 to 4 weeks depending on the patient preference, and they lower LDL cholesterol down to levels that we previously thought were unattainable. We're getting patients down to 10, 20 milligrams per deciliter of LDL. And more importantly, we lower LDL and we prevent recurrent heart attacks and strokes.
And just to put that number in context so it's clear, we trigger treatments if the LDL and nothing else about the patient is at 190. And we know that that's been associated with disease. And now we're talking about therapies that will take that malignant level of LDL and get it down into the low double digits. That's pretty impressive.
It is. And where it's more exciting is the number of patients that have cardiovascular disease that have LDL levels that 10, even 5 years ago, we would have thought are controlled. We can lower their LDL levels even further and decrease their risk of recurrent events. Somewhere on the order of 15 to 20% relative risk reduction for PCSK9 inhibitors.
But now both of us are clinical scientists, and we know that not everybody needs to be on a PCSK9 inhibitor or even has an indication for one, even if someone made an argument. Because we're thinking now very carefully about secondary prevention, someone that has had an event, so we're removing primary prevention for a bit. We may come back to that in time. And we're thinking about, for that patient that's already on therapies, here's this effective therapy, but you and I have both written about the fact that cost is an issue.
Yeah.
Where are we with that now?
Yeah, the truth is that at the sticker price of $14,000, which fortunately has now been lowered, we're at less than $6,000 a year. And with rebates and other things, really the cost to insurers is probably even lower than what we're looking at in the $5,000 to $6,000 a year range. But even at that level, we can't afford as a society to treat every single patient with cardiovascular disease. And so we've had to be thoughtful on identifying those who are going to benefit the most.
So this is great. So for our listeners, you can really help everybody today. Tell them very crisply, who do you think is indicated for a PCSK9 inhibitor today?
Yeah. So I'll do even better than tell people what I think, which is try to summarize what the guidelines think. So the 2018 Multisociety guideline parallels a couple of other major guidelines by the AAC and the National Lipid Association. The idea is find the patients with cardiovascular disease that are at the highest risk of recurrent events. And we know who those patients are. People with polyvascular disease, people who have had multiple events, and those who have multiple comorbidities like diabetes or chronic kidney disease or residually high LDL cholesterol. Those are the patients who are at the highest risk of recurrent events and are likely going to benefit the most on an absolute scale from therapy. So it's really a way to maximize the value of these treatments. And this is a new era for us because even when I was in training, every patient with heart disease, coronary disease was treated the same. Everybody got a statin and then you were done.
But now we're discriminating risk, which is great. So as we wrap this up, let's re-emphasize that the first and second steps in this thought process, lifestyle,
right?
The diet, and yes, the statins. The statins should be used correctly. So what are the impediments to statin use? They're cheap, if I can say that, available. Side effects are way less than advertised. They're very much manageable by any practitioner, simple prescription. So what are the impediments?
So we studied this in a large cross-sectional observational registry, and the number one reasons why patients decline or discontinue statins is because they experience or they fear side effects. And the challenge is that for a lot of our patients, their perceived side effects are actually a nocebo effect, where the fear of the side effect itself causes them to experience it. And a lot of that is being fueled by false information that is being promulgated throughout the internet in both Facebook groups, documentaries, websites that are selling alternatives to statins, where you can go online and find out that statins cause just about any horrible side effect that you've ever heard of.
So let's assume that if we can, we'll give ourselves a license to say that we are articulating what we believe to be an evident truth. And we believe that evident truth is that on balance, risk-benefit taken into consideration, we believe that statins are appropriate to prevent disease and appropriate for people that already have disease and are a necessary step going towards these new therapies. I want to close with a really fun question. What's in the future in this field?
Oh, the future is so exciting. So first of all, the future is here. The results of the REDUCE-IT trial showing a 25% relative risk reduction for icosapent ethyl in patients with high triglycerides was another standing ovation in the field of prevention and lipidology. And there's two new therapies coming out. One, bempedoic acid, which is an oral LDL lowering agent that is being targeted to those people who have statin intolerance. And then what I'm most excited about is inclisiran, which is a long-acting medication that is
like every 6 months?
Every 6 months, even potentially up to 9 months or a year. We're thinking about being able to treat LDL cholesterol with almost a vaccine-like model where you can get one shot and not have to think about it again until your next follow-up visit with a cardiologist.
So, Dr. Navar, I think you've given all of us the wow moment for our discussions about what's germane, what's most pertinent, what you need to know now. Yes, everything we do is risk-benefit, and conversations with patients have to drive those decisions. But boy, we've got some spectacular data, and it's just been summarized by one of the best minds in the field. I couldn't be happier that you're here. Thank you so very much.
Thank you again.